All. Good evening, everyone. So we'll be starting up with the 19th session postgraduate case presentation, which is initiation of Ampok. So today we'll be having a case of lung cancer, and the case will be presented by Dr. Sridhar from Aster MIMS, Kozhikode. We have two examiners, Dr. Vijay Patil from Indira Hospital, Mumbai, and Dr. Jayashekhar from Lisi Hospital. So I request the examiners to take over the proceedings. Over to you. Thank you.
Vijay sir?
Yeah, I'm ready.
Yeah. Sir, shall we start?
Yeah, please start.
Sir, I'll start now, sir.
Yes.
Good evening. So today I'm presenting the case. Coming to the presenting complaints, my patient is a 67-year-old female who's a resident of Kozhikode, Kerala. She presented with a history of worsening breathlessness since 2 weeks, also with a history of non-productive cough, also for 2 weeks. History of presenting illness. My patient presented with a history of cough for 2 weeks. It was non-productive in no significant aggravating or leading factors, no diurnal variation in symptoms, no positional variation in symptoms. She also gives a history of worsening breathlessness over the last 2 weeks. It was initially present on exertion, but currently she gets breathless on walking a few meters with significant limitation of activities of daily. She was evaluated for these symptoms at the local hospital where she underwent imaging, and in view of a suspicious lesion on imaging, underwent biopsy and was referred to our center for further care. Patient there is no history of fever, no history of hemoptysis, no history of wheeze in the present audible wheeze, no history of pedal edema, facial puffiness, no history of abdominal distension, no history of back pain or bone pain, no history of headaches or seizures, no history of discoloration or sclera or urine, no history of change in quality of voice, no history of fatigue, weight loss, or loss of appetite. Past history. The patient is a known case of COPD since several years, and she is on inhalational therapy. Patient gives a history of recurrent exacerbations and admissions for exacerbation COPD and admissions for the same over the last 6 months. There is no history of TB, hypertension, CAD, CVA, or type 2 diabetes. Personal and family history. The patient is a smoker. She smokes approximately 15 to 20 BDs every day, and she has been a smoker for more than 30 years, and she is continuing smoking. Patient mixed diet, normal bowel and bladder habits, and there is no significant family history. So in summary, we have a 67-year-old female patient who is a current smoker and a known case of COPD with a history of recurrent exacerbations in the recent past, presenting with a history of non-productive cough and worsening breathlessness over 2 weeks, referred after imaging and biopsy done from a local hospital.
What are your differential diagnoses after this history?
Sir, one will be an acute exacerbation of COPD given her history. Possibility of pneumonia can be considered, but points against it would be the lack of fever or any other constitutional symptoms. In view of the patient's history of smoking, age, and the treatment history of biopsy being done, differential diagnosable lung malignancy can be considered, sir.
Why is not tuberculosis featuring in your list?
But only 2 weeks history is there, and there is no history of fever and non-productive cough. There is no history of any diurnal variation of symptoms, no history of evening rise of temperature, no constitutional symptoms, and the history is only present history is only for 2 weeks.
So that a 2-week history, no history of constitutional symptoms, no history of weight loss, then I would be reluctant to even keep a malignancy as a differential.
Yes, the malignancy is only because she has undergone image.
Understood. Because you understood. Okay, I'll give it that to you. Okay, fair enough. Tell me a few things. Can you go to the slide of your negative history?
Yes, sir.
Yeah. So why was history of wheezing asked?
Sir, because she is a known case of COPD, that is one. Second, again, if there
is a known case of COPD and she never had his previous history of wheezing.
Oh, in this admission, sir, in this
Okay, in this admission. Okay, fair enough. Why did you ask for history of abdominal distension?
sir, since she has undergone a biopsy, whether and we are keeping a differential diagnosis of malignancy to rule out any metastatic spread. So liver mets with fluid, I mean ascites or any different.
Unlikely, na? If you had a liver mets and then see the thing is, na, the more you give the examiner such options, na,
Yes,
the
sir.
more you will unnecessarily get stuck in history.
Yes, sir.
Okay, if there is abdominal distension, the patient will tell you there is abdominal distension. So what we need to ask is for relevant negative history, na?
Yes, sir.
The back pain, bone pain is okay, headache and seizures is okay, discoloration of sclera also. And you would ask for discoloration of urine. It's very difficult for patient to tell that this is discoloration of sclera, na?
Yes, sir.
Okay, change in quality of voice is okay, history of fatigue, weight loss and loss of appetite is also okay. Fair enough, fair enough. Go to the BD histories of BD which she was taking. So how do you quantify the smoking?
Sir, smoking is quantified in pack years, ideally. If the patient has smoked 1 pack per day for 1 year, it becomes 1 pack year. 1 pack, it is for cigarettes, it's taken as 20 cigarettes.
Why?
Sir,
How many cigarettes are there in one packet of cigarette? How many cigarettes in one packet?
20 approximately.
Oh, so there are no smokers in this group? In India, it is 10. My question is why 20 is taken as the number?
Uh,
The reason is this was formulated in developed countries where the packet has 20. That's why.
yes, sir.
The second is you told that any quantification for BDs?
There is a BD, I don't know the exact quantification, sir, for BDs.
Yeah, so there was an index which came from PGI Chandigarh. You might read about it. It was called Zindal Index, and that said the number of BDs which are smoked per day multiplied by the uh, number of years. Okay, but the problem with BDs is that many a time they're locally made, so the content of tobacco, length of the BD might change from various brands to brands. So, how is smoking related to lung cancer? What is the relative risk and what is the attributable risk of smoking for development of lung cancer? And what's the difference between relative risk and attributable risk?
Sir, more than 80% of lung cancers are seen in smokers, but for
Okay, so you mean to say that if there are 100 lung cancers, 80 will be smokers. Is that correct?
yes,
What you
sir.
mean to say? Is that the data from India? That
No,
if you see 100 lung cancers, 80 will be smokers. Is that the data from India?
sure about the Indian data, sir. Yes.
You must know about Indian data. Na? You are going to practice in India, na?
Yes, sir.
So I would expect you to go and read about an epidemiological paper which was published by Dr. Dikshit. It's in Indian Journal of Cancer. A huge data set from Tata, and which was followed by similar data sets from AIMS and Kidwai have also published. You would be really surprised to see how many smokers get. If you have 100 lung cancers in India, how many of them are smokers? I'm not going to give the answer. I want you to go and read it.
Yes, sir.
Okay.
Yes,
I
sir.
would join your next class just to see that and ask this. I want you to type the answer in the chat box. Okay. And you would be really surprised how many non-smokers get lung cancers in India. Okay. So coming to the question, what is relative risk and what is attributable risk of smoking? What do you mean by relative risk?
Sir, relative risks.
So relative risk is nothing but a kind of a ratio where you look at the incidence amongst those who have the like the incidence among smokers or incidence amongst non-smokers. Okay.
Yes, sir.
Attributable risk is incidence among smokers, correct. Incidence among exposed to non-exposed, correct. Attributable risk is incidence amongst exposed minus incidence on non-exposed divided by incidence among non-exposed. So you actually try to find out what is the attribution of that exposure to the condition. Which patients, if some smoker comes to you and say, I read that I have a risk of lung cancer, and doc, can I do screening? So which patient would you advise screening, and how would you advise screening?
Sir, screening, low dose CT scans can be used for screening.
What do you mean by a low dose CT scan? And what is a normal dose CT scan?
The total radiation exposure low dose CT scan is 1.4 million sieverts, and in a regular CT it would come to around 7 million sieverts.
What is sieverts?
The radiation unit.
No, it's not the radiation. What do you mean by sieverts? What I mean to say is, so what is gray? What is sievert?
So sievert.
So you must have seen that radiation occurs at writing 70 gray, 35 fractions, or
Yes.
50 gray. Yeah, someone answered that for you. Yeah, it's the absorbed radiation dose. Okay.
Yes, sir.
Okay. So the gray is what you deliver. What is absorbed is explained in terms of sievert. So when you tell these words, no sieverts, millisieverts, you must understand their meaning. Okay.
Yes, sir.
Yeah, so whenever you read, just try to get the details of this. So tell me, when would you want? When would you want the screening to be done by a person?
Sir, patients, the high risk population, the elderly, so more than 55 years of age with a history of more than 30 pack years of smoking. They
Sure,
would-
it is 30 pack years, not 15 or not 20.
30 pack years.
Okay, and what would you advise? So you would advise a low dose CT scan for how many years? At what interval?
Sir, annual low dose CT.
Hmm?
So, and then if discontinuation can be done after smoke, one is if there after smoking cessation, more than 10 years of smoking cessation, or if there is limited life expectancy due to other comorbidities. Otherwise, screening will be done annually till
So, which trial you are quoting when you are saying that, like the National Lung Screening Trial, which was initially published, for how many years did they screen? Any idea?
exact how many years?
What one of the criteria which you showed was correct. It was between 50 above 55 years. 30 pack years is also correct because you quoted this 55 and 30 pack years. That's why when I asked you about the criteria of National Lung Screening Trial.
Yes, sir.
Okay, so it was they screened them for 3 years, annually for 3 years. Okay.
Yes, sir.
Yeah, and now how many patients, if you do a low dose CT scan, what is the catch you get? Am I audible?
Yes, sir. Yes, sir.
So what I was asking you is, what would be the added incidence of lung cancer in those patients in whom you would do a low dose CT scan as opposed to in whom you would do a chest X-ray only? Any idea?
No, sir.
So the added is not much better. It is around 75 added cases per 100,000 person years. Okay.
Yes, sir.
So the number is not so many. Does doing a low dose CT scan has a survival advantage over X-ray?
No, sir. There is no survival advantage with either X-ray or low dose CT.
Sure.
There is survival.
Yeah. Because my next question was going to be how much it is, That's okay. So just read up about this. Huh? See, normally when we talk about lung cancer, we don't go in those areas. Go ahead. So go ahead with your general examination. Yeah.
So general examination, the performance status is 2. ECOG PS is 2. The patient is moderately built and nourished.
How do you assess performance status?
So performance status one based on the patient's activity compared to baseline before disease status, whether they are full 0 will be fully active and able to carry out all pre-disease activities without any restriction. 1 would be strenuous activity is restricted, but able to carry out activities of sedentary nature. Second, PS2 will be they're ambulatory and able to carry out self-care, but for more than 50, they're up and about for more than 50%. While 3 would be limited self-care and they are bedridden for more than 50% of the time. And 4 is completely disabled, cannot carry out self-care.
That 50% of the time which they are bed care, is it during the daytime or in the night time?
So when the patient is active, sir, not during.
Yeah, correct. What is the full form ECOG?
Sir, Eastern Cooperative Oncology Group.
Okay. Very good. The performance status assessment is a general examination finding or a history finding?
Sir, history.
Yeah, we normally talk it in general exam, but it's actually a finding you get on history. Go ahead.
No palatal cyanosis clubbing, no lymphadenopathy, no spinal tenderness.
Why were you looking for clubbing?
Sir, because history of, we are suspecting lung cancer, so clubbing can be associated.
So what are the types of clubbing? What are the grades of clubbing? And what is the typical about clubbing which is associated with lung cancer?
So the hypertrophic osteoarthropathy is a paraneoplastic finding in lung cancer.
Correct. How do you test for it?
Sir, we look at the angle that is first we can look at the distortion of the nail bed and the
When I am asking about the hyperosteotropic, how do you look for that?
X-ray findings, sir.
Okay, go ahead. It's at the breast, that's correct answer, yeah. Go ahead.
So the pulse rate is 72 per minute, right arm normal rate, rhythm and volume. The BP is 110/70, right arm supine. The respiratory rate is 30 per minute.
Would you want to look whether there would be discrepancy in the pulse rate between the right and the left side in lung cancer? And
Yes.
can this why?
Sir, if there is the vessel involvement.
No. So someone answered that SVC, but no, it's very difficult in terms of both SVCO. I anticipated someone and superior sulcus tumor to get a discrepancy in pulse rates. Okay, so it's very difficult. You might get it's easier for the veins to be collapsed with the pressure, but not arteries. Okay, so it's very rare to get a difference in right left pulse rate because of lung cancer itself. Okay, go ahead.
Coming to systemic examination, the respiratory rate is 30 per minute, is thoracico-abdominal breathing. Intercostal retractions are seen, trachea central. There is no visible pulsation, scar size of fistula, and no distended veins. Palpation, the trachea is again central. Apex beat is in the 5th intercostal space. Chest circumference is 80 centimeters with an expansion of 2 centimeters. On percussion, there is a dullness to percussion noted in the interscapular region over the right side. Auscultation, bilateral bronchi are heard over both lung fields. There is decreased air entry again in the interscapular area over the right side. Coming to the other systems, the CNS examination, high mental functions are normal.
Breather, can I interrupt?
Yes, sir.
Yeah. Should you be looking for Horner syndrome here in a CL lung case?
Yes, sir.
Yeah, why?
Sir, the superior sulcus tumors can lead to Horner syndrome.
Yeah, what's it mentioned here?
No, sir. I'm mentioning cranial nerve palsies, but specifically Horner syndrome, I have not mentioned, sir. The process.
Okay. Yeah, go ahead. Go ahead.
CNS, there is no cranial nerve abnormalities noted. A motor system moving all four limbs, reflexes are normal. Sensory system, no sensory deficit to pain, touch, temperature. Per abdomen, soft, non-tender, no organomegaly. CVS S1, S2 heard, no added sounds or murmurs, and the JVP is not raised. So again, summarizing. So it's a 67, my patient is a 67-year-old female who's a current smoker and no case of COPD with a history of recurrent exacerbations in the recent past. She presented with history of non-productive cough and worsening breathlessness over a 2-week period, referred after imaging and biopsy from a local hospital. She has, on examination, decreased air entry on the right side and associated dullness to percussion, suggestive of possible mass or consolidation of the right lung in the background of COPD. Here, the differential would be a mass or consolidation of the right lung with acute exacerbation of COPD in the history, in view of a history of chronic smoking, age, and the treatment history from the outside hospital, from the local hospital. We would like to consider possibility of carcinoma lung. Sir.
Vijay sir, any questions? Sir?
Yeah. Yeah, go ahead. Why do you think this is any other differential?
Sir, differential will again be exacerbation COPD and pneumonia. We can also keep as a differential, but there is no other findings which, I mean, history-wise also there is no this thing which would go for pneumonia or TB. And in view of the treatment history, I would like to keep the carcinoma lung as the first probability in this. With an acute exacerbation COPD.
So when we talk about an SP case, we talk about a structural diagnosis and etiological diagnosis. So why have you said MAS as a structural diagnosis?
Sir, in view of the percussion findings, which is showing dullness, and there is no associated if the percussion was due to an effusion, there is no signs of any tracheal shift or mediastinal shift, and it is in the middle lobe, it is not a lower lobe. I mean, the findings are not in the lower lobe. Again, going against any other effusion or any other etiology.
Okay, fair enough. How will you investigate this case?
Sir, investigation, we would first do a routine, the routine blood investigations and metabolic parameters, which include a CBC, a liver function test, electrolytes, renal function test.
Whenever you have been asked to ask for investigation, better you say investigation for diagnosis, investigation for staging, and investigation for fitness. It
Yes.
shows that you have some clarity over the subject. So can you put this investigation in these topics and tell me?
Sir, these would be investigation for fitness of the patient to see the metabolic parameters, the liver function and the renal function. So we would like to go ahead with a staging investigation in this case.
Can you elaborate on this general investigations? Like, actually, will you specifically look for some electrolytes or?
Sir, we would look at the sodium levels, hyponatremia. For hyponatremia, we look at the calcium and renal function tests, creatinine clearance to calculate the creatinine clearance, and the blood, complete blood count and differential count, just to, because again, to get the fitness of the patient.
Okay. By looking at sodium electrolytes, actually, what are you looking for?
Sir, hyponatremia, SIDH is a paraneoplastic syndrome seen in
yeah, and that is associated with which type?
sir, it is more common with small cell.
Yes. It is more common with small cell, but can also be associated with adeno. And go ahead.
Then for the staging investigation, we can do a PET CT for the staging in case of CA lung. If PET CT
Why
is-
do you specifically want a PET CT? Why CT is not enough?
Sir, if the CT, if we are doing the CT, we'll have to do a CT thorax, abdomen plus a bone scan. PET CT is
So
still in,
that is the only reason why you want to do a PET CT, to save time.
Sir, and the PET positivity plus this CT correlation adds to the predictive value of the mediastinal staging, whether we need to go ahead with a invasive biopsy or not.
What is the sensitivity and specificity of PET CT for mediastinal staging?
Sir, the CT findings are divided into 4 groups. If there is a discrete mediastinal, the 4 groups, one will be where there is a diffuse.
The question was something else.
The pool sensitivity is 80% sensitivity and 80% specificity.
Okay, approximately you comes close to here. So what are those 4 groups which were you were mentioning to?
Based on the CT, basically we divide the tumors one with a where a discrete node cannot be made up. There is the diffuse mediastinal infiltration, but there is no discrete node. In this case, the CT itself, the false positive rate for a CT is very low, and hence invasive mediastinal staging is can be avoided. Then there is discrete mediastinal nodes.
No, you didn't mention the CT finding, no?
No, sir. CT finding is not mentioned. Like in these groups are for the CT and the
you can go back to the investigations. You actually I asked this question when you were mentioning CT thorax abdomen. You can proceed from there.
Yes, sir. So we can do a PET CT that will cover both the mediastinum and the metastatic workup. And the initial investigation for any patient, because this patient has already had a CT done from a local hospital. That is why we go ahead directly for a PET, only a PET CT.
So what is the PET finding?
This is the PET CT of the patient. So there was no extrathoracic lesion. There was one the right-sided. There was metabolic uptake in the right-sided lesion. Plus there were hilar nodes, and there was a separate nodule in the opposite lung that was sub-centimetric but with metabolic uptake. And this was the PET CT report. So there was the metabolically active primary lesion, 4.5 into 4 into 3.9 centimeter in the right lung, with a subcentimetric right hilar node, suggestive regional metastasis, and active nodule in the left lung lower lobe. That was also suspicious for metastasis.
When will you say that it is PET avid? If the nodule, regarding a nodule, when will you say that it is PET avid? And when will you say it is PET non-avid? What is the cutoff or comparison? You say it is PET avid when the avidity of the nodule is more than that of the mediastinal blood pool.
Yes, sir.
Okay.
Yes.
Proceed.
So this was the PET CT. Now then for diagnostic workup, we need to get a tissue diagnosis. Since this is a central lesion, we can go ahead with the EBUS ultrasound guided biopsy for the tissue diagnosis.
So, how do you select a lesion for biopsy in lung cancer?
Sir, the most easily accessible lesion should be taken in a metastatic disease. We need not take from the thorax. The most easily accessible metastatic site also can be biopsied. If we are biopsying the lung lesion, if it is a peripheral lesion that can be accessed via CT or CT guided biopsy, we can go for a CT guided biopsy. Central lesions, it is the
Can you tell us uh, how are the mediastinal lymph nodes numbered?
the mediastinal nodes are numbered depending on the location. There are different zones. The zones, there is the upper zone that is the upper cervical
If
supraclavicular.
I say that the lymph node number is 12 versus the lymph node number 2, what do you get from that number?
So the higher numbers, the 12 nodes are the hilar and the peripheral nodes towards the periphery of the lung. And the 1, 2, those nodes are the upper nodes which are in the cervical or the upper areas of the lung. So the numbering is from above to the periphery.
Okay, great. What is the midline in mediastinal lymph node classification? How do you say it is a right lymph node or a left lymph node? What is the midline? What decides it? So my question is it the midline which divides the mediastinal in right and left, or it is something else?
Sir, the right and left for each level, it is different, the anatomically.
No, it is not. Please read the mediastinal lymph node numbering, and you need to know what is the midline. The midline is not the midline. Okay, that's the reason why I'm asking, and it becomes important. So, what is N1, N2, N3?
Sir, N1 will be ipsilateral.
No, midline of trachea is not the midline, huh?
Yes.
That's a wrong answer. Okay, someone just put in a chat box. Please read it. I'm not going to give you that answer. You need to read it. Which line divides the mediastinal lymph node into right and left? Okay, and tell me what is N1, N2, N3.
Sir, N1 is the ipsilateral peribronchial and ipsilateral hilar nodes. Plus the intrapulmonary nodes will be in the N1 nodes. N2 will be ipsilateral, the mediastinal nodes, ipsilateral and the subcarinal. And N3 will be contralateral mediastinal, contralateral hilar, any scalene node or supraclavicular.
When you say this contrary, the line becomes very important.
Yes, sir.
So many wrong answers given that I won't have given this answer, but the trachea's left side border of the trachea is the midline. Okay. Okay. So if you have a midline lymph node, mediastinal, it is ipsilateral for the right side. Okay. But a midline lymph node will be correct. That's correct. Taruni Bhattacharya has given the correct answer. The left side of the trachea. Okay. You need to know this. The second is you told EBUS. What is ROS? ROS.
Sir, Rose. Sir.
If you use EBUS, you need to know what is ROS. ROS is nothing but rapid on-site evaluation. Okay, yes. That's correct. As it has been put by many in the chat. What is its utility?
Sir, if the entry node is positive, we do not have to go for staging for the other.
No, the issue with ROS is it as the name suggests, it's something like a frozen, so it tells you rapidly. Okay, that is its utility. Okay. Okay. So it's what is the stage of this patient on the basis of this PET scan?
Sir, the stage would be a T2. Right hilar is positive, T2, N1 and M1A because of a contralateral lung nodule.
Okay, fantastic. So move ahead with the investigations.
So we got in the biopsy, the EBUS biopsy. The right hilar node was positive for metastatic adenocarcinoma. Paratracheal node was positive. And we also had the initial biopsy taken from the outside hospital had also shown adenocarcinoma. Then after the tissue diagnosis, since it is a metastatic adenocarcinoma, we would like to go for the molecular testing on this patient on the
Fantastic work. What is so? What test will you use for molecular testing?
so we can go for the multi-gene, I mean the NGS testing for this patient, sir.
So so what will be what will be like what we do is as the what I'm trying to say is what are the genes which you are looking for?
Sir, we will look for the targetable oncogenic mutations. So most commonly, we look for the EGFR, ALK, ROS mutations. Others, the other mutations we look for are the KRAS, HER2, and the molecular screening also involve other
Hi.
the TP53, PIK3 mutation.
Okay, so tell me some common EGFR mutations you know of.
Sir, EGFR, the exon 19 deletion, the L858R mutations, and then the other uncommon, I mean, these are the most common with exon 19 being almost 50% and 40% being the L858R. Remaining about 10 to 20% are the uncommon mutations.
Fantastic. Why don't you want to go for CGP? What is CGP?
Comprehensive genomic profiling.
Okay. Why don't you want to do the CGP beta?
That's it. Cost would be an issue.
What are the various methods by which usually we evaluate for look for molecular markers? You told NGS. What are the other methods
Sir,
which
we prior to NGS we can use IHC plus FISH to look for the EGFR, ALK, and ROS.
what specifically which one for what?
Sir, the EGFR can be done by immunohistochemistry, and the FISH panel for ALK and ROS.
EGFR is usually previously we used to do by RT-PCR, ARMS PCR. Okay.
Yes, sir.
Yeah, and FISH.
FISH for the fusions we can use ALK and ROS are the fusion.
No, FISH can be used whenever there is a rearrangement. Okay, like it could be ALK, ROS, RET, NTRK, even the HER2 FISH, MET. Okay, so whenever there is a rearrangement, we used to look for the FISH.
Yes, sir.
Okay, and RT-PCR we used to do for EGFR, and in colon we used to do for KRAS and BRAF. Okay, now everything has been replaced by NGS. These days, will you still use IHC for any marker?
Sir, again, the tissue availability is an issue. So
how do you look for PDL1?
Sir, PDL1 is looked for by IHC, sir. For the PDL1 by IHC.
You know any platform by which PDL1 is usually done?
Sir, the SP2 263 is one platform which is used for the IHC assay, which is used for PDL1, and then the SP142 is also there, sir.
Okay, good.
So this was the genomic test. I mean, the molecular testing, the report. KRAS, PIK3, and TP53 were mutated in this patient. The PDL1 was also done, which was less than 1%. So,
Okay. Okay, so what are you seeing in this report?
sir, this is the the molecular study which has shown one, the KRAS mutation is seen. Plus two other mutations are the TP53 and the PIK3A.
Okay. G12V. What are your thoughts on KRAS?
Sir, the KRAS right now G12, that is not a targetable mutation, the G12B mutation.
Okay. What are the implications? Let's say that if you see a KRAS mutation, what things come to your mind?
KRAS mutated tumors are seen more commonly in smokers, and there is a
Why would you want to know that? Yeah? You already know that the person is smoker. So what implications you get after looking at KRAS?
KRAS mutated tumors have a more tendency to be more responsive to be immunotherapy. Normally, oncogene driver mutated tumors are not responsive to immunotherapy, and the driver mutation targeted therapy is more effective. But in KRAS mutated tumors, the immunotherapy has been shown to be effective.
If it is accompanied with KEAP1 mutation and STK11 mutation, still it remains the same. It's a KRAS with a KEAP1 and an STK11. Still, they are more responsive to immunotherapy.
Sir, I am not sure about that.
So what?
One more person is can discuss them after a few days.
So see, so
And
there is one
is there
MSKCC
a-
meta-analysis which showed that if you have KRAS mutation, KEAP1 mutation, and STK11 mutation, patient don't respond much to immunotherapy. So KRAS is peculiar. If it is only KRAS, what you said is correct. The response to immunotherapy are higher than what you see with other mutation. Yeah. If you have other accompanied with STK11 and KEAP1, then it is a different ball game. So let's say that this was KRAS G12C for this discussion. Okay, what would you have done?
Sir, again, there is no targeted therapy in the first line. So, but we and the PDL1 score in this patient is less than 1%. So, therapy-wise, depending on the patient's fitness, we can consider the combination of chemo plus immunotherapy. But targeted for therapy for KRAS in the first line, it is not yet shown any benefit.
Okay, what is the PDL1?
So less than 1%, sir.
So what do you want to give?
Sir, we can give a combination of chemo plus immunotherapy, sir, with a pembrolizumab plus platinum-based doublet.
Okay, what is the age of this person?
Sir, patient is 67 years old.
She is 67 years. She has COPD. Her performance status is PS2.
Sir,
So
based-
I say that I might go. She's KRAS mutated also. I say that I want to go with this patient for a nivolumab, ipilimumab with paclitaxel carboplatin, and it's adenocarcinoma.
yes.
Nivolumab, ipilimumab with paclitaxel carboplatin. After 2 cycles of paclicarbo, I would just continue with nivo-ipi. Am I wrong? So what I'm asking you is in PS2 patients, what are and less than 1%, what
Yes.
are the treatment options you have? Let's not take about immunotherapy. Let's say chemoimmunotherapy versus only chemotherapy. What is the benefit of immunotherapy? Let's dissect that out.
Considering the patient's performance status, background of COPD, we can consider actually single agent chemo initially. And if the patient is responding, and because initially we would like to get the manage the COPD, because it is a small T2 lesion, but the patient is having breathlessness on exertion. So the symptoms are more likely to be due to the COPD rather than the malignancy per se. So after adequate management of COPD, along with single agent chemo, if the patient is symptomatically better, we can consider adding on the doublet treatment.
So let's stick to this point that if the patient is PS2 and you want to use single agent chemotherapy, let's say that I want to use a double agent chemotherapy. So in a PS2 patient, is there any study showing a benefit of double agent chemotherapy or a single agent?
That's not sure.
Do you want to do a comprehensive geriatric assessment in this patient? She's the elderly lady. She has COPD.
Yes.
What are the advantage of doing a comprehensive geriatric assessment in this patient? So see, if you see an elderly now, always get a comprehensive geriatric assessment done. The comprehensive geriatric assessment should tell you about three things: whether the patient is fit, whether it's vulnerable or she's unfit.
Yes, sir.
If she's unfit, you see if she can be corrected and made vulnerable or fit. If she's vulnerable, try to see that if she has any issues which can be corrected. Even the geriatric assessment also gives you details about what are the chances of developing adverse events, and accordingly you could decrease it is कितना adverse event के लिए कितना percentage decrease कर सकते हो dose. So that would be my choice in this. Now for the less than 1%, less than 1%, less than 1%, less than 1% PDL1.
Yes, sir.
So less than 1% है तो whether you use pembrolizumab, whether you use nivolumab, whether you use atezolizumab, the benefit of adding immunotherapy is less.
Yes,
But
sir.
there is some data to suggest that when the it is less than 1%, probably Nivo-AP might have a more role to play, but that's all probable. You may use any of the immunotherapy agents, but the benefit, the delta is less. Okay, so if someone wants to do only chemotherapy, I won't say it's doing anything wrong.
Yes, sir.
Okay, so whether this patient had a pain,
No, sir. Okay.
let's say that the patient had pain and you had to give NSAIDs.
Yes,
Would
sir.
you still give pemetrexed, carboplatin, and pembrolizumab to this patient?
Sir, NSAIDs and it will with pemetrexed generally is quite.
So, what is the relation between pemetrexed and NSAID? How much creatinine clearance is required if you want to give pemetrexed in a patient on lung cancer, if he is on NSAID and without NSAID? So it is 80 ml per minute if its NSAID is going given concurrently, or else it's 45 ml per minute.
Yes,
Okay, that's correct. Someone answered correctly, 80 ml per minute. That's correct. So let's say that this patient for this discussion had KRAS G12C, you gave him pembrolizumab, and the patient came with history of fatigue,
Yes,
and
sir.
consistently there is fatigue. What will you do?
Sir, since the patient has received fatigue, we will first assess the metabolic. Since the patient has received immunotherapy, one possibility we should keep is immunotherapy related side effects. Second, the disease related. So, the patient, since it's a lung cancer, hyponatremia can be a possibility, and the patient.
Correct. You would do electrolyte. You would look for anemia. All those is normal. What else?
Then related side effects, especially the hormone.
Correct. You would do that ACTS, TSH. What else? Which is one of the very common hormones, which deficiency of which can lead to, not in females but in males.
Levels, testosterone levels should be.
Correct. You also look for testosterone in males. Don't forget to do that. So that is okay. Let's say that the patient fails after How many cycles of pemetrexed carboplatin you want to give?
Sir, 4 cycles and then we'll reassess, sir.
Why 4 cycles? Not 6 cycles. Why not 6 cycles?
The no benefit has been seen with 6 cycles.
Okay, okay. Okay, was there any study of comparing 4 cycles versus 6 cycles of chemotherapy? Yes, correct. Someone answered that correctly. Yeah, which showed that there was no benefit of fear. So on pemetrexed, if the patient is ongoing, and let's say that we are not given pembrolizumab, patient is only on pemetrexed, why do you give vitamin B12 and folic acid with pemetrexed?
Sir, sir, it
Why
is
do
a-
you give vitamin B12 and folic acid with pemetrexed?
So the supplementation with B12 and folic acid has been shown to reduce the side effects of
With side effect.
hematological side effects.
Pemetrexed is with side effect, beta? See, when pemetrexed was developed in the phase 1 setting, the development program had to be stopped because of severe myelosuppression, and they saw that the severe myelosuppression was associated with the higher levels of homocysteine. And because there were high levels of homocysteine, that's where the idea came that let's give vitamin B12 and folic acid to these patients. And surprisingly, after giving vitamin B12 and folic acid, it was seen that the levels of myelosuppression actually came down. Okay, my question is, what is the recommended dose of folic acid with pemetrexed? Yeah, it is 500 microgram. That's correct. So normally we get a 5 mg tablet. So if you exactly want to give 500 microgram, you need to use the pediatric solutions which are available. What is the dose of vitamin B12 and how frequently you give it with pemetrexed?
Sir, every
1000 microgram is the correct answer. Let's say that the patient fails. We have this class till 8:30.
yes, sir, 8:30.
Yeah, we can go up to 8 till 8:45, Vijay.
Okay. So let's say the patient fails after 5 cycles. Okay, what will you do? And let's keep it that this patient has been treated with only pemetrexed carboplatin. After 4 cycles, you stop carboplatin. So 5th cycle was with only pemetrexed. The patient has failed. Now what do you want to do?
Sir, again, reassess the patient's fitness, performance status, and other whether because patient's current condition, and then
Okay, fantastic. How many, if you have 100 patients who took first line therapy, how many go on to take the second line therapy? Given in the chat box is correct, it's around 60%. Okay, so what is the option this patient has? Let's say that this is KRAS G12C.
sir, one option would be second line chemotherapy would be an option. Then
Correct. One will be docetaxel, one would be sotorasib. Docetaxel is difficult to administer in such patients. Sotorasib will be an option, but many times you might just want to give some weekly chemotherapy in these patients. What is the role of early palliative care in lung cancer?
Sir, ideally, in metastatic disease, palliative care should not be at the end of life. Palliative care should be considered even at the diagnosis itself, and it should go hand in hand with the treatment. Especially if the patient has symptoms such as pain, the relief of those symptoms would lead to improvement in quality of life and better compliance with treatment per se. So,
Okay. Okay. That's all from my side. I won't trouble you any further. If you have any question to ask me, you can ask me.
Sridhar,
yes, sir.
will you not suggest as the first step smoking cessation for this patient? She is a current smoker.
Yes, sir. Smoking cessation should be advised to all patients.
So usually when we were students or when we appeared, actually, this is the first point that we were supposed to mention.
Yes, sir.
Okay. Why? Is there any advantage?
Since continued smoking along with treatment has been shown to have more what I mean, those patients who continue to smoke favored poorly while giving treatment because of the smoking related problems per se, and especially since lung cancer, you have multiple
Smoking
other.
cessation is actually smoking cessation is associated with around 45% reduction in lung cancer mortality and also in all-cause mortality. So that is why smoking cessation is actually should be the first step. Okay. Nothing else from my side also.
Thank you, sir.
We have completed the session, 8 o'clock. I think we could have, if there is no more further questions from the examiners, we'll call the session off. So thank you, Dr. Sridhar, for an excellent case presentation. I would like to thank Dr. Vijay and Jayashekhar for an excellent discussion on this topic. So we will be coming back with a new case next month. Thank you. Vijay, thank you, Vijay. Yeah, I can see a comment that is this recorded class available? Yes, we are recording the classes. You can the classes are available in Ampok website. So you can just go into the Ampok website. All the classes, all the previous classes, everything is there in the Ampok website. I think like in the ISMBO Young Oncologist group also the classes, the recorded sessions of this class is available. People are still typing the same thing. So I just want to repeat that the classes are available in Ampok website as well as in Young Oncologist, as well as in the ISMBO website. ISMBO has got a separate thing for Young Oncologists. You can get it there. Otherwise, you can get all these classes, the previous classes, everything will be there in the Ampok website, AMPOK Ampok website. Thank you all.